Hello, I am Dr. Andrew Sanderson, Harvard Chan School of Public Health class of 2016, where I earned an MPH with a focus in health policy and management. I'm also a current member of the Alumni Weekend Committee. This year, the committee chose Public Health Through the Life course as a theme for Alumni Weekend. Lightning Talks are a chance for us to highlight stories from the diverse experiences of fellow alumni. Today, I am pleased to introduce Dr. George Tolomiczenko. George is a 1995 graduate of the Harvard School of Public Health, earning an MPH in healthcare policy and management. Dr. Tolomiczenko serves as executive director of the Merkin Institute for Translational Research at Caltech. His interdisciplinary experiences in Canada and the United States as a clinician, researcher, professor, and senior administrator jointly inform his inclusive approach to promote innovations that improve health and healthcare delivery in both academia and the nonprofit sector. Translating research advances to improve healthcare requires breaking barriers and customized tailoring to sustainably address identified healthcare needs and solve a variety of vexing problems. Throughout his career, Dr. Tolomiczenko has always worked with diverse sets of stakeholders to create new paths to cures and improved access to affordable, high-quality healthcare. Welcome, Dr. Tolomiczenko.
Thank you very much, Andrew. And it's an honor to be giving this talk. It's a bit of a walk down memory lane, and you'll see in subsequent slides that memory lane often has to sort of switch back to black and white images from past papers, and I apologize for the illegibility of those in advance. This is a journey, also a personal level journey that I'm going to share, because my research really was enabled by my links and perspective that I initially got in Boston. It was grounded in Boston, and I was able to sort of use my time there to get better educated through coursework and the relationships I had with people at the School of Public Health, and some of which I continue to have too. So I'll talk a little bit about that. And my journey starts with a focus on homelessness and mental illness. And in particular, what I learned in Boston and how I transferred that north of the border to Canada, and where it blossomed there and has continued to be finding its place in work that some of my students are doing even now here in the Los Angeles area. Okay. So this slide, it really sort of summarizes the Boston work. I was very much attracted to the concept, the very novel concept called evolving consumer households. Dr. Stephen Goldfinger and his team at the then Massachusetts Mental Health Center, we were one of 5 national projects that were demonstration projects out of a second generation of the McKinney demonstration projects. And what each of us of the projects was doing is looking at different approaches and on housing loss for persons with severe mental illness. So I really started literally on the ground level with this. So my role, having trained in clinical psychology at Boston University, was to actually go and do all of the structured clinical interviews for potential subjects of the study in Boston. That means I had to, interview, in fact, more than 118 subjects who eventually were included in the sample, for example. And one of the things that I learned at this time is, having trained in clinical psychology and having a very strong research interest, I often had to be forced, or I was asked, how can you be a clinician when you've done all that research? And how can you do research if you're focusing some of your time on clinical work, which was really a puzzle to me, because back in the day, that program was training clinician scientists. So here I was in a situation where I was doing both, and I think one of the reasons why I explored public health as a next step was I realized that it was one place that welcomed both sides. And I'll say a little bit more about this through the rest of this presentation. So, there were different cities doing, as I said, trying different approaches, and it was also really helpful to learn about these other approaches. So assertive community treatment in Baltimore, critical time intervention in New York City. So I really had a diversity of tools that I absorbed in my role, first at the ground level, but by the time the research was winding up, I was the director of research and I was participating in the joint meetings with the other sites. We also collected different types of data that included ethnographic observations, so day in the life of, immersing ethnographers, anthropologists in living situations, and neuropsychiatric assessments. So I was familiar with both those dimensions of assessment in the Boston site. So what I learned was you can do wonderful things for clients, subjects, but over time, even those with severe mental illness wound up being pulled back into their own catchment areas, also sort of required to be seen by people providing services in those catchment areas, and in a way undoing the work that we had been doing for 3 years, housing people, and I would say successfully, and empowering patients, and I would say successfully, in living situations with the right level of support. So meanwhile, I got married, and my wife and I thought, wouldn't it be wonderful to move back to Toronto? This is a slide. This is only the second time I've posted this, but it's a slide that says, okay, I've been working in a lot of places. So and there's not even a card for my time on the McKinney demonstration project that I just described. But at the time, I was also participating in other research in Boston, but I moved to Toronto. I was recruited while I was a student at Harvard, because the then person in charge of the Health Systems Research Unit, Dr. Paula Goering, was looking for a methodologist and had been looking for a methodologist for 2 years. And when she saw that I was interested in, as I called it, what is it like to be an adult in Canada, because I had left to do my undergraduate work in the United States, she said, if you can finish your MPH degree in a year, I think we need to talk more. And that wound up moving me and my wife across the border. And so there I landed very quickly to continue the type of research. And this is why Dr. Goering was interested in bringing me on to look at homelessness in Toronto at first. So this was the Pathways into Homelessness project. And I helped write the proposal for this project actually before I moved to Toronto, while completing accelerated studies in Boston at the now Chan School of Public Health, and it was a very busy time, needless to say. But what I was able to do was bring much of what I'd learned about the looking at persons with severe mental illness south of the border, north of the border. So I also brought with me a keen interest in technology tools to enable this type of research. So for this project, I vividly recall sort of starting with fax machines to scan in data, and then switching to scanners, and then customizing software. And as I like to describe it now, I was beginning to feed big data. It was sort of baby data at the time, but larger amounts of data on individuals and what that are important in collecting. Now, the Pathways into Homelessness project, I was able to use what I learned both at the School of Public Health and at in the um, in the program, the McKinney Demonstration program, to really selectively sample such that our interviewed included subjects were representative of Toronto homeless individuals. So this was not meant to characterize families who were homeless, for example. And I think one of the things that makes this a different study is that in the larger population, when you zoom out and look at people using shelters, you find a higher prevalence of first of all, affective disorders and comorbidity with substance abuse disorders as well. And this is part of what we found, what we did. And the key thing that I was doing on this project that I learned was, how do we expand and go outside the structures of, say, for example, the structured clinical interview for diagnosis? Because I had learned personally how important this was from interviewing people who, for example, didn't qualify based on an initial go through of the questions in a structured clinical interview. They basically said, no to anything that would be touching or involving post-traumatic stress disorder. But when I sort of queried scars, for instance, on that I could see on a young Black woman that I was interviewing, she mentioned, these were, like friends were chasing me, and they cut me as they were chasing me. Now, ordinarily, so I learned to appreciate how important it is to understand the context of events like that, and how they can be differently perceived, especially through a filter of major psychosis, for example. So in Toronto, I wanted to make sure that we were more appreciative of qualitative aspects. And one of the things I did right from the start was to talk to shelter workers about what kind of research questions made sense to them, and did they need answers about, to help them provide service better for their patients. And I found that one of the areas of interest was understanding personality disorders a bit better. And I really dove into that in my personal research as well at the time. Again, this is going back a long time ago. And I was there in Toronto thanks largely in part to Dr. Paula Goering. I mentioned her earlier, and she was very open to my getting the sort of the word out about how we need to do research differently. And so this article was one example, the process and politics of community-based research with people currently homeless. And in it, I basically outlined what I did as I described just now, mixing qualitative and quantitative research, forming questions with end users in mind. And that's largely what we were doing here. And I think I'm very proud of this. And in fact, it sort of echoes in my mind after reading a New York Times article this weekend about how public health issues really have to understand the sort of local political context. It was sort of based on even some of the early words of Virchow in this area and on this topic highlight this. So this is my pathway away from research with homeless persons. The short form of this story is, here's a paper that, again, a different approach, a different angle on all the data we were collecting, gender differences in legal involvement among homeless shelter users, again with Paula. And it took a long time for this to make itself to publication. And as you all are aware, in academia, it's publish or perish. But I chose a third way, namely, get out of academia, purely academic stance. So when the journal lost my manuscript and the entire file, I thought, this is the writing on the wall saying, explore new avenues, George. And but I want to say that even though I've gone in different directions, emphasizing more my sort of technology and technology innovation, bringing engineers to work with medical people. I still am very supportive and often consulted to do reviews and to participate in research with homeless populations. So first off, I was able to do that with continued relationships with people back in Toronto. So even when I was in Canada working in a hospital context, I continued to work with people such, and a special shout out I say here to Dr. Stephen Huang, who also graduated with an MPH from Harvard School of Public Health, I think a year after, or a year or two after I did. And I've always enjoyed working with him and continued, and on and off still continue. This is probably the most important paper summarizing a huge project in Canada that came out, led by Dr. Goering and including Dr. Huang. As I say in the last point here, I'm very, special heartfelt acknowledgement to Paula Goering. Unfortunately, she passed away in 2016, not long after visiting here in Los Angeles, as a matter of fact. So these cards again, only because at this point I really transitioned to more of the science focus, especially the move down to Los Angeles, where I've led a program at USC. And this program was with the School of Engineering and the medical school. And one of the outcomes of this program was creating a digital health group. Very keen students, bright students who I had the pleasure and challenge of teaching while I was at USC, have really sort of dug in and established an arm of their now Aikido labs focused on providing tools that hinge on data interoperability. This was the student group included Jared Goodner and Hugh Gordon, who are the co-founders of Aikido Labs, and then they brought in another student, Karthik Murali, who actually has had a special focus on homelessness. Just to mention also that one person from USC is now at Harvard, who it would be a very valuable sort of link for the School of Public Health in wicked issues like homelessness that persist. And he runs the Center for Artificial Intelligence focused on social issues. So that's all I have slide-wise, and I thank you for your attention. I want to make sure that I thank all the people that I mentioned in the slides, but also the broader audience. I really value my continued links with the School of Public Health, and I wish we could do this in person.
Definitely. George, thank you for that presentation. I have one question for you. You've studied homelessness both in Canada and in the United States. Do you feel there are any key differences in management approaches or outcomes?
The one thing a phrase that I remember from one of my professors at the School of Public Health, George, you do the we thing well in Canada, and we do the I thing well in the United States. And I think that that's a key difference. I mean, the housing first, large assessment protocol that I included in this slide set is an example of a national program that really sort of, it's like what the McKinney demonstration project was on steroids, in some ways, and getting that implemented on a very large scale, involving many different stakeholders, and then building in a knowledge translation piece was one thing that I would say Canada does an excellent job at, and in some ways the United States could learn from our friends north of the border, which is why I continue to make sure that I am involved with the Canadian Institutes for Health Research on a variety of different ways, most recently on the advisory board for the Institute for Nutrition, Metabolism, and Diabetes.
All right. Well, thank you very much. That concludes our lightning talk.